this evening. Briefly, I'll be joined by Dr. Sam Martin and Amanda Tutty. But first, I'd like to make an acknowledgement to country. I'd like to acknowledge the traditional owners of the land on which we meet today. Most of us are sitting on Bundjalung Nation, and we pay our respects to the elders of the Bundjalung Nation, both past, present and emerging, and to any Aboriginal people attending to tonight's event. By the end of the hour, we hope that you have a much deeper understanding of how knee and hip joint replacements can be done as same-day surgery, and that you will be able to help improve your patient outcomes who are having this sort of surgery. We hope that you can improve your ability to optimise the pre-operative management of such patients, including recognising appropriate physiotherapy in the management of osteoarthritis of the knee and hip, and be informed about how same-day joint replacement surgery is now being achieved in Grafton. So I'd like to welcome our presenters tonight and ask Sam and Amanda to turn their cameras on. Hello, Amanda, welcome.
Hi, thanks, Peter.
And we'll just, Sam's coming on soon.
It won't let me start my video. Oh, here we go.
There he is, great. So Sam, we'll start with you. So thank you so much for tonight. Just can you briefly introduce yourself to the audience?
Hi, I'm Sam Martin, an orthopaedic surgeon in the Clarence Valley and doing a bit of work in coughs. I've been in Grafton since 2011.
That's great, Sam. And what brought you up to the Grafton area?
Well, my wife was actually a GP trainee and in the Northern Rivers training program.
Fantastic. So general practice is bringing more specialists to the area.
Exactly, yeah.
Good to hear. And Amanda, what about yourself?
So I'm a physiotherapist and I have a dual role. So I've been a physio head of department in the Clarence region for around the last decade. And for the last few years, I've been providing orthopaedic early assessment clinics, predominantly for patients with arthritis at the Grafton Specialist Orthopaedic Centre.
Fantastic. Well, thank you both for coming along tonight. So most people who are joining the event tonight or who are listening to this at a later date will probably be aware that there are advances all the time in joint replacement, and that particularly in this region, there's been a big push for pre-assessment with physiotherapy to either to better manage osteoarthritis of the knee and hip, to either delay or maybe not even need the replacement, and those who proceed to replacement have better outcomes. And tonight's event is a little bit different to that. Perhaps you could see it as an extension in terms of the cutting edge and the advances in joint replacement. Tonight is going to be about people who are having same-day surgery. So that's going in and out on the same day as your joint replacement, which when I first heard that sounds pretty crazy, but having chatted to Sam previous to this sounds very exciting, and I'm very pleased to have him here tonight. So Sam, can I let you start your talk, please?
Thanks very much, Peter. Look, this does also dovetail though with what you're talking about in terms of the pre-op workup and preparation, and that's very crucial to the success of this sort of program. So yeah, thanks for the opportunity to present this talk with regards to our pilot program of day surgery total knee replacements at Grafton Base Hospital. So we don't have any conflicts of interest to declare. There's increasing demand for efficiencies in this field. There always has been, but the COVID pandemic has placed even more pressure on our stretched public system and private system as well. So if we can find ways to provide more efficient care, that's clearly going to be beneficial. Joint replacements are high volume procedures. You know, in the last good year, 2019, or as people say, you know, I think there are 100,000 total joint replacements done, and the post-op course for those patients is quite variable. You know, we hear about average lengths of stays of 5 days, and rehab referral rates range hugely. The average rehab referral rate might be as high as 20% in the public system and 40% in the private system, with some facilities having almost 100% rehab referral rate in the private system. So lots of variation and lots of potentially inefficient care. We hear a lot about the private system death spiral or strain on private health with raising costs of private care, and obviously the stress on the public system is greater. Next, please.
And Sam, just briefly, with COVID, how much surgery have you been able to do in the last 12 months?
Yeah, well, Grafton, we've had our own problems with a steriliser that was out of action, in fact, so that was probably more significant than COVID. But yeah, certainly lost many months of operating, and things much worse again in Victoria or Sydney. So we were even fairly lucky as far as that's gone. But yeah, big effects, and the steriliser problems in Grafton certainly compounded that. So we noticed at Grafton Base Hospital over the years, with the introduction of various measures to have patients more comfortable or more functional, we've noticed decreasing lengths of stay as time's gone by. Next. And from overseas, we know that outpatient, same-day surgery is actually safe and efficacious. So the rates of readmissions and complications in the same-day group is very comparable to inpatient arthroplasty. So is it safe and reasonable to do that in Australia? Is still a bit of a question. We implemented a pilot program in August of 2020 that ran for 12 months, and essentially did a bit of research reviewing our practice registry, looking at the day surgery group of patients compared to unilateral knee replacement patients in the same period. And the pilot was quite prescriptive in terms of well-documented selection criteria and the sort of information the patient had to be provided with, the rehabilitation and workup strategy, surgical and anaesthetic techniques, discharge care, criteria, and post-op care were all sort of described as that in that program. These are the selection criteria, which are fairly generous. We can perhaps talk about them later if there's anything specifically that somebody wants to go into. But we do feel this is something that's appropriate actually for many patients, except extremely obese or extremely elderly or with uncontrolled comorbidities. Next. So the sort of surgical and anaesthetic factors or the points that permit or facilitate this sort of surgery are many, but I've just tried to highlight a few here. So assessment for suitability was a bit of a three-pronged sort of process with discussion between surgeon, anaesthetist, and allied health. Certainly some robust process there is and was important. The pre-op education is truly crucial. So patients were given a quite detailed information booklet that was sort of outlining the pathway and what to expect post-op and how to get ready pre-op, and that as our stays have gotten shorter and shorter, the information, the detail and importance of the information patients are given before the surgery has gotten more and more more important. The optimization of these patients we can go into a little bit now. All our joint replacement patients benefit from being in good shape before the surgery, and that's especially true in the shorter stay group. Essentially, we're checking for and managing or addressing any anemia, any uncontrolled comorbidities, uncontrolled cardiac issues or diabetes or whatever need appropriate workup. Staph carriage, we undertake swabs and we clear patients of skin or nasal, often just methicillin sensitive staph carriage. That's been a bit of a battle to get the labs to report on that as well, because there's quite focus on MRSA, which is actually only about 5% of community staph carriers. Anyway, so there's lots of sort of detail we can go into there. And the prehabilitation, which is that sort of physio, partly the assessment, education, and then the work, so the patient's actually putting in some work to get in good shape for the surgery. A suitable anaesthetic needs to be administered, but we have found what that is can be sort of at the discretion of the anaesthetist, as long as they're doing an anaesthetic with day surgery in mind. So that can be spinal, it can be general, or it can be a combination. A high dose of systemic corticosteroid is certainly beneficial with induction. We did a subvarsous approach, which is a less invasive approach, and we use minimal tourniquet use, just a single dose of IV antibiotics and tranexamic acid to minimise bleeding. The local anaesthetic infiltration is a particularly important step. So that is a cocktail that also includes corticosteroid. And we've been doing that on the way into the joint in the approach. And, the motto there is to undertake the infiltration as if it was a procedure like a skin cancer excision or something that you're doing under local anaesthetic only, so trying to get into all the little nooks and crannies. Otherwise, a standard arthroplasty and, a normal, careful waterproof closure, local anaesthetic pump, a nice bandage, and a flexion pillow, amongst other many things. Next.
So Sam, I'm just interested to know, so compared to what you do in the past for non-same day surgery, what out of those things about selecting the patients and what you're doing during surgery, and we'll obviously talk a bit about what happens afterwards, but up until this stage, is there much difference? Or is it more just conceptually that it's possible you can actually do it?
No, look, there's been sort of incremental, it's interesting. So it's very much an incremental process. I suppose the selecting patients for day surgery was a bit of a step change, right? Because before we did day surgery, we weren't selecting patients for day surgery. But, all these other things we've done to sort of decrease pain and improve function have been incremental, and no one feature is particularly crucial. You can leave out any one ingredient of this sort of recipe and essentially have the same effect. If you decided to do a different approach, you wouldn't notice the difference. Or if you decided to use a tourniquet, you wouldn't notice the difference. But if you leave out 6 of the ingredients, well, then suddenly the patients are going to be in pain and have poor function and stuck in hospital a few days. So it's, our initial journey, I showed that chart where we sort of came down from 6 days to 2 days, was this incremental change of, changing one little thing, creeping up with the dose of dexamethasone, the more routine use of tranexamic acid, even the flexion pillow post-op decreases bleeding a little bit. So all these little things add up.
Yeah. And what about you, Amanda? Have you noticed a difference in the way that you've done things in the past?
Well, I guess we've had a program for quite some time to help prepare people for surgery from a physical and, comorbidity lifestyle factors perspective. It's been a little bit of a change over time in staff, including physios on the wards, being prepared to see patients come out of surgery in a good state and to get them moving early on and on the day of their surgery. So that was sort of a shift in, I guess, culture over time. But apart from some of the preoperative education and selection, all of our patients in Grafton have this approach. So even those patients that aren't appropriate to go home on the day of surgery will still be optimised to be discharged as early as, and safely, appropriately. Yeah.
But we have been, it's fair to say probably that over the years, we have been putting more effort into that pre-op stuff as the years have gone by. So that, day surgery patients do need that extra bit of information, education, and, the other patients get benefit from that too. I guess 8 years ago, patients just sort of used to turn up and have their operation and didn't know too much what was going to happen, perhaps. So that there's certainly been an evolution to more work preoperatively. Would you agree?
If you go home on the day of surgery or even 24 or 48 hours later, you're not taking in a lot of information during that period. So the more that we can have them prepared before in terms of understanding the recovery process, their pain management, their wound management, what the likely recovery and things to watch out for are, the more prepared and confident they feel, I suppose, that that this is going to work and that they're going to have a successful early discharge. 100%.
Yeah. And other people benefit, all the patients benefit from that same amount of pre-op education. Yeah.
So there's a few questions coming in. One is, why is high-dose steroids so important?
Yeah, I suppose less nausea, less pain, less swelling, very powerful anti-inflammatory drugs. It's maybe potentiates the effect of local anaesthetic. There's some research I've seen that local anaesthetic blocks with steroids in the block, either steroids in the block or steroids systemically, actually potentiate the effect of the block in ways that perhaps we don't understand. So that's a good question. But
so is that steroid intra-articular or is it?
Well, both. So there's steroid mixed in with the anaesthetic cocktail, but then there's also intravenous dexamethasone with induction. So steroids everywhere. Steroids
everywhere, yeah. And I was just interested about the you talking about the infiltration of the local anaesthetic and how you do it like you'd be doing like a skin excision. So is that a new was that a new thing brought about by day surgery, that understanding that increases or decreases pain post-surgery?
Yeah, I guess so. I mean, that's my own motto. I've sort of come up with that.
Right.
But I guess a careful local anaesthetic infiltration technique is certainly part of this. So, but yeah, I mean, it is something that as surgeons often we don't do well. We sort of squirt a bit of local anaesthetic in the skin flaps at the end of the case and think we put some anaesthetic in. And then a large part of my, learning with this over the last 5 years is just how much better you can do it than that, right? You can put local anaesthetic in a whole lot better than that. And it's interesting in that that's something I can teach someone else in 20 minutes. I mean, it's not, it took me 5 years to learn it, but it's easy to teach someone else.
Yeah.
So that's something that surgeons, we can all do better. And I'm still changing how I do that. But I think that's had a lot to do with how patients are more comfortable. And then interestingly, they don't end up in a bad way once the anaesthetic's worn off. I mean, the anaesthetic we're infiltrating, we can really only expect to give any relief for 24 hours. When it wears off, these patients are still comfortable. If they get off to a good start, it sets them up for a more comfortable day 2 and 3 in ways that I don't really understand. That's probably partly to do with sleeping better. It's probably partly to do with not having those high doses of opioids from the beginning. It's perhaps to do with the expectation that they didn't wake up in agony, so they're not set up for that expectation. It's going to be very sore.
Yep.
Yeah, but having a more comfortable 24 hours initial 24 hours has, positive flow-on effects.
That makes a lot of sense. And I'm not sure about what this stands for. I'm a bit embarrassed, but someone said PDSA for total hip replacement. Do you guys know what PDSA stands for? Maybe that person can let us know.
There's a thing called direct superior approach. Is that where there's different ways into a hip? Is it relevant to the approach to the hip?
I'll let that person spell out what PDSA means for me. I'll plan, do, study, act is what it stands for.
Right. Okay.
Yeah. Okay. So someone else has asked a little bit about the in regards to the evidence-based conservative management versus surgical management, whether maybe there's some selection bias because of the way you're only selecting certain fit patients with in the previous criteria about body mass index and comorbidities and stuff. Do you have any comment on that, or do you know the research intimately enough to be able to talk about that? Or
sorry, well, there were a few sort of parts to that. So there was conservative management.
Well, I think the question's about the impact of using evidence-based conservative management on knee osteoarthritis, and a patient's better selected at the moment for the same day.
Yeah, I mean,
therefore getting better post-op recovery because of the selection we're using.
Yeah, so I guess look, all these patients go through a process where they're trying conservative management first, unless that's clearly doomed because they've got a collapsed femoral condyle or whatever. But really, 99 times out of 100, a trial of, well, not trial, a course of conservative treatment, a course of non-operative treatment is absolutely the first line thing. And yeah, I think we do get better results from arthroplasty, for the ones who don't get sufficient benefit from that to avoid the surgery. Well, they've still had the benefit of the exercises and fitness improvements, etc. In terms of selection bias for this cohort, look, there's no doubt that there is a selection process. So we are trying to select the fitter, healthier patients for this, the day surgery process. Absolutely.
Yep.
Amanda, have I answered that okay?
Yeah, I think yes.
Really well. I think the only other thing is that one of the things we learned was that, yes, they need to be reasonably well and not have like a poor anesthetic comorbidity profile, but mostly the patients just needed to have a low level of anxiety, and those psychosocial factors were really relevant, so that people that felt confident and had good social supports, even if they were 75, 76 years old, and had poorer function, like people who couldn't walk so well because of the functional limitation of their joint, actually were still quite capable of going home on the day of their surgery. So that level of self-efficacy, which probably in part is to do with those personal characteristics, as well as their previous experience of conservative management, and certainly came into play in terms of this when we started looking at who was appropriate.
Yeah. And someone wants to know how much GPs are involved in the assessing suitability.
Yeah, that was something that we did in the hospital system. So that was after they were, after they'd had their go of non-operative management. Some of them avoid surgery. Of the ones that don't avoid surgery, well, then there was the discussion between anaesthetics, allied health, and surgical unit about suitability. There's no reason that GP would or could not be involved in that, but that wasn't, I suppose, the model.
That wasn't the model,
for this pilot. Yeah. That's a good question.
Oh, being a GP-focused audience, we're pretty keen on that.
Sure.
So yeah, so look, that's good. So why don't we move to the next slide, because I've got a feeling it's going to bring up all this stuff around discharge, which people are wondering about too, I suspect. So
right. Well, I'll just tear through that quickly. So look, the discharge was very much standard. So patients were going home with short-acting analgesia, so oxycodone immediate release, 5 milligrams QID, tapentadol immediate release, 50 milligrams QID PRN. Most patients had rivaroxaban 10 milligrams a day for DVTP prophylaxis. Patients attended the office 3 days after the surgery for the local anaesthetic pump removal. And that was really the only departure from the standard care that all the overnight patients received. The overnight patients had their pumps removed prior to discharge in general. So physiotherapy follow-up was standard. Patients did also get a phone call within the first 24 hours of surgery to check they were okay, which I think all the day surgery patients at Grafton get. Physiotherapy, the first visit was 10 days after the surgery to the physiotherapy unit department, and a wound check at sort of 2 weeks. So there were no physiotherapy or nursing home visits, or no home visits of any sort, no sort of extra steps there compared to what everybody else gets.
So the removal of the LA, that's the local anaesthetic pump. Is that what LA
Yes, yeah.
So even though it's coming out at 3 days, they're not actually using it while they're at home. Is that right?
Oh, sorry. Yeah, that's a little pump that infuses anaesthetic constantly for the first 72 hours.
Okay.
So it's filled up in theatre, and then it has a constant output, 5 mils an hour of 0.4% Narapin over the first 72 hours.
Yep.
A pain buster is the name. Elastomeric pump is the non-brand name.
So few more questions coming in. So
we're not getting very far.
No, it's good. No, we're getting really far. This is excellent. So the question is about what do you see as the impact? So, and also Amanda, please answer this too. As you see the impact of the sort of the strength-based training and attempt at weight loss on I guess patients who end up having surgery and potentially patients who can avoid surgery?
Yeah, so I think education, exercise, and weight management are 100% our first line treatments for all people with knee and hip arthritis. That is an important part of working out who does and doesn't need a joint replacement in a lot of cases. And I think in primary care, our role in particular providing quality education and advice to patients is really important. And one of the things we talked about, Peter, earlier is that something I see really commonly in my clinic is that patients are really fearful of moving when they've had a flare-up of their arthritis and they're not sure what's safe and what they should be doing. And probably the most important role we can play at that time as physiotherapists and GPs is to provide them with reassurance that it's safe for them to use their sore leg, that they're not going to cause more damage. And quite often we disable people when they're already fearful by telling them to stop and to rest for prolonged periods. And there's some sort of, really key important messages, that reassurance that they can't cause more damage, that they don't have to avoid pain altogether, and giving them permission to, to move and to use their leg is really important. And if they are in a flare-up and they're not sleeping, then just addressing those fears and addressing with pain management, their sleep can really help to de-escalate their flare-up and their pain. So, and then your longer term, that stuff around strengthening and weight management, if you de-escalate a flare-up, then it's like these lifestyle factors and exercise and activity, these are the way that we can best self-manage our knee arthritis. And for a lot of people, that will settle things to the point that they can carry on without a joint replacement for a long time. But if they do need to have one, then they're going to recover faster and have a better outcome if they've done those things anyway. So it's really, really useful.
Yeah, that's great. Sorry, we're jumping around a bit there because we sort of jumped into prevention. So sorry to put you off your line of thinking there a bit, Sam, but that's really helpful, Amanda. And I think if we touch on that again at the end, we'll go back to that. So there was another question, just getting back to the surgical side of things, whether the surgical approach is identical whether you're doing same day or non-same day.
Yeah, so that is, this whole thing is identical, aside from the going home on the day of surgery, and the coming back 3 days post-op to get that pump out. The rest of the pathway is all the same. So all the pre-op education, prehab optimization, the information pack, all of that's all the same. The surgical pathway, surgical techniques, anesthetic techniques, all the same, and the post-op stuff all the same. And that's actually something I wanted to touch on later. We see that this protocol has got benefits for everybody. Okay, so it's not just beneficial for your 50-year-old who can get back to sport more quickly. It's beneficial for your 95-year-old who for sure doesn't go home on the same day, but has less physiological insult from the surgery because we've made it more comfortable and they return to function more rapidly. And so that patient might be in hospital 4 days instead of 4 weeks and is less likely to get AF and delirious and less likely to have some other, fall in hospital and whatever. So it's not the case where I was actually thinking before this webinar about a way to sort of explain that. And I was thinking of racing cars where, a sporty car that suits a 50-year-old might not suit a 95-year-old. But this is not the same situation, so the 95-year-old will get the same, potentially greater benefit, to be honest, because really, I guess, does it really matter that much whether a 50-year-old spends no nights or 1 night in hospital, and does it really matter that much whether they're 3 weeks off work or 4 weeks off work? It's not so different. Whereas the 95-year-old, I really feel that it can make the difference between some sort of fairly major complication or not. That patient's actually, and the feasibility of the surgery or not. So older people actually probably have more to gain from this approach than younger people, even though they don't go home the same day.
Yeah, no, that's a really interesting answer, Sam. And it's such an interesting topic, because in medicine we often just do the same thing over and over again without questioning it, and there are so many examples of that we do every day, and this sounds like it was one of them. And
Yeah, right.
it sounds like to me that it's been like, obviously there's some stuff you're doing a little bit different. You talked about surgically, all the little bits you're adding in, but is it mainly been a cultural shift in just the way you can think about this, that you can actually do it?
I mean, expectations of
yeah.
everybody involved come into it as well. The expectations of the patient, the expectations of the GP who's referring the patient, expectations of the nurses, the expectations of the physio, expectations of the doctor. Everybody's idea of what's normal has had to change. Absolutely, yeah. And that's been an incremental change, because you notice that actually patients don't need to stay 5 days; they can stay 2 days. Or if they can stay 2 days, maybe they can stay 1 day. And also that patients don't want to stay in hospital. They want to go home, right? And
no, really,
right?
I believe you.
Right. Well, in the private system too, that's interesting. So I mean, there's pushback. So I mean, in the public system where we're talking about resources, it clearly makes sense, but it does. We'll get onto that in a minute. When we get past this slide, it does appear that the day surgery is actually a better patient experience. And that's the same in the private system, where people have paid for a comfy bed. Well, actually, it's still not as comfortable as your own bed. So days, right, never, right. You don't sleep in hospital, the day surgery is a better experience. Getting better quicker is clearly preferable to getting better slower.
Yeah. No, that's great. So let's go to the next slide.
So some results. Okay, so we had 17 day surgery patients and 100 overnight knee replacement patients in the period. Almost all of the planned day surgery patients successfully discharged on the day. And as we just said, the day surgery patients were very satisfied with the experience. So all the day surgery patients felt satisfied with the overall experience. They all felt well informed. They all had a preference for day surgery if they had to have another surgery, and they all would recommend that to a family or friend if asked what the preference was for how long to stay in hospital. The rate of emergency department presentations was actually lower in the day surgery group, and the one patient that did presented for a very minor reason, being a checkup of the pain pump, and there were no readmissions or reoperations in the day surgery group.
And was this from out of your practice, this study, or this was something?
Yeah.
Yep. Fantastic. It's great you're doing your own analytics. That's really good.
All right. In terms of patient experience, so the video on the left shows a patient who had done a whole lot of prehabilitation. So she, credit where credit's due, she did put a lot of work in before the surgery, but walking nicely independently 3 days after the day surgery knee replacement in the comfort of her own home. And the patient on the right is getting up out of bed on the day after his surgery, getting ready to go home. He needs to get changed before he goes home.
They're really they're amazing videos. I was just thinking of the last patient I saw who had a knee replacement, who comes and sees me for a dressing change. They're never that mobile.
Well, clearly I chose the best videos.
You chose the best one. Yeah, I think my sample size is pretty small too.
But no, I mean, patients can walk around really well on the day of surgery. They do get a little bit sore at day 2 or 3, but as we see with the lady on the left, not unduly so. Next slide. This is actually the gentleman who was getting out of bed 4 weeks after his day surgery knee replacement, back kite surfing. And if you look in the top left, there's a whale breaching. Oh, there it is.
Oh, wow.
Anyway, we can.
So how many weeks post-surgery was that?
That's 4 weeks.
4?
Yeah.
Wow.
So I suppose I make the point that these patients aren't suffering down the track from not having inpatient physiotherapy, so they get off to a good start and then they stay doing well. Next slide.
I notice he's wearing the shark deterrent stripy wetsuit too.
All right. We presented a patient story to the district health, and I think some of the sort of extracts from that are interesting. So the patients commented that the whole day was a really good experience. When she went home, she slept the whole night, which would never happen in hospital ever. The next day, she got up and able to look after herself independently. Family came to visit and couldn't believe how independent she was. And the levels of pain were low. The patient was comfortable with nothing stronger than Panadol, which was actually a reasonably common finding in this day surgery group. To be fair, there's some selection bias. We've tried to select fitter patients who are going to be good copers, but really these patients were often not taking much in the way of analgesia. It didn't feel like major surgery. Patient felt well informed, as Amanda said, felt equipped and confident, which is totally crucial. And yeah, if they needed another knee replacement, they would do it the same way. Looking at some patient-reported outcome scores, the two groups had sort of similar levels of disability prior to the surgery. And the day surgery group actually had a bigger improvement in the first 6 weeks. So the difference between the two groups at 6 weeks, comparing day surgery to overnight, actually almost reaches the minimum clinically important difference for this score. And then, both groups improve from there on, or the day surgery group maintains that from there on. But again, just making the point that the day surgery groups certainly aren't doing worse because they miss out on inpatient physiotherapy. Next slide. The day surgery group also might be more comfortable. So as part of this research, we asked the patients daily for the first week, what to score their worst episode of pain in the preceding 24 hours. And almost half of the overnight group had at least one episode of severe, being 8, 9 or 10 out of 10 pain at some time in that first week. Whereas in the day surgery group, only a quarter of, or less than a quarter of patients experienced even one single episode, which could be quite short-lived. The question wasn't about how long, at least, experienced any one single episode of severe pain at any time in the first week, acknowledging selection bias. But, I suppose that also speaks to the selection process, because there wasn't really any crossover. So, all these patients were selected before the surgery. Next slide. So the little bit of research I've just presented obviously has low numbers of papers and is retrospective, but it does appear that day surgery knee replacement is efficient, and we didn't need any extra out-of-hospital resources aside from the patient visiting us, one extra appointment on the 3rd day post-op. Day surgery knee replacement appears to be safe, comfortable and satisfying, and associated with a rapid return to function. And we've learned lots of things along the way, but here are some of them. So quadriceps lag and severe pain aren't necessarily part of total knee replacement recovery, and day surgery protocols actually protect against barriers to day surgery protocols. Day surgery, when I first heard about day surgery, I wondered how on earth did people get out of bed on the same day without being dizzy and falling over, because lots of our patients were dizzy on the 2nd day after the operation. And then it becomes apparent that the actual act of giving them an anaesthetic compatible with day surgery and then getting out of bed and walking around on the day of surgery protects against dizziness. Local anaesthetic infiltration is super important, and rebound pain is manageable. Patients can still walk on the day of surgery if we don't treat them as if they've forgotten how. And our patients still wanted to go home at 8 p.m. We had a few patients who weren't cleared for discharge until well into the evening, and I'd sort of assumed that those patients would just say, oh, it's late now, I might as well stay in hospital. And, they didn't want to. They wanted to go home to the comfort of their own bed. Wouldn't surprise me if they wanted to go home at midnight, if they were allowed to. I don't think, we had a couple of discussions with people from Victoria Health and New South Wales Health about introducing these sort of protocols. It's my opinion that can't be introduced in a top-down fashion. It probably needs to be something that doctors and patients and physios and GPs and all our stakeholders take on board and champion. And as we had touched on before, this sort of protocol can apply, the benefits apply to all our patients, and possibly, mostly, in fact, to the most frail and elderly who aren't day surgery candidates at all.
So can you sorry, just go back to that slide for a second. So what's quads lag?
Oh, sorry, quadriceps lag. So, when I was a registrar, every single knee replacement patient used to have a dead leg for 5 days. The quadriceps would just totally switch off, and some of them wouldn't switch on again, in fact, for quite a while. And interestingly, I'd never heard an orthopedic surgeon talk about why that was happening or ways to minimize it. It turns out it's got a name, arthrogenic muscle inhibition, and it's reasonably poorly understood complex spinal reflex. But there are things we can do to diminish the strength of that reflex. In fact, to the point where most of our patients don't really get any period of dead quadriceps now, or minimal. So that's been interesting. So I guess part of what you're saying about, we shouldn't be taking things for granted. The barriers to recovery often melt away if we think about what's going on and ways to address it. So in conclusion, day surgery doesn't appear to be at the expense of the patient, which I think is a common misconception amongst orthopedic surgeons. So I think lots of my surgical colleagues think that these sorts of programs in America or whatever are really just cost saving or cost shifting or whatever sort of bizarre side effects of the American health system, and somehow involve shunting the patient on or decreasing the safety or experience for the patient, and that really doesn't seem to be our experience. So, and I really just think that's a misunderstanding. So the day surgery protocols are more enjoyable for the patient. All those patients wanted to do it that way again.
Yeah. So, look, it's just fascinating. Cultural changes in surgery and medicine are always, big changes in the way we do things. It's always interesting to think how you got there and how it's happening. So it's really interesting to hear your story. I think we need to, I'd like to just probe you a little bit more on that, and perhaps Amanda as well. So I happen to know that the same day surgery for joint replacement, knee hip replacement is going to start potentially within a few weeks' time at Lismore Base Hospital as well. So that's hot off the press from one of the orthopaedic doctors who got in touch with me this evening and unfortunately couldn't make it. So in terms of GPs who are going to start seeing this and patients who are going to be experiencing it, for someone yourself, Sam, who's taken this from the very beginning and now you're doing it all the time, so I was going to say tips for GPs, but you've just given a lovely talk on it. But just to summarise, what when we start seeing these people walk through the door, is there anything that you think we should start particularly trying to do in regards to these patients now that it's going to be coming more into the northern part of the region?
I guess it's that whole pre-op, the whole sort of journey, isn't it? From pre-op optimization, trial conservative management, etc. But I guess your question was more about post-op.
Pre-op too, yeah.
So I think I heard that, we were, and Amanda and I, in fact, were both involved in another webinar, and the phrase came out, first better, then quicker. And I think that was that's a good phrase. So we first need to get our pre-op pathway and optimization really down pat, and we need to get our post-op pathways perfected, and then we can sort of look at quicker. So I guess it's all just a matter of doing everything as well as we can, as we would for all our patients. But this is probably an area of medicine where sort of protocolized care is quite relevant. Lots of these issues for these patients are, sort of repeating patterns. So just having a streamlined, effective pathway, and in terms of post-op, I think the communication channels are crucial. So the shorter the stay is, the more important the information that the patient is given becomes, and then also the more important that the communication channels become. So if the patient does run out of medication, or if there is a concern about something being wrong, well, you can't just pop round to the ward and have a look because the patient's not on the ward anymore. Interestingly, that really doesn't come up much. I think once we've got our processes streamlined to the point where this is workable, we're really not seeing an increased number of concerns or presentations or whatever. But if there is one, well, having that open communication channel, patient, doctor, physiotherapist,
how do you deal with it?
General practitioner, orthopedic surgeon, is really crucial. Yeah.
Yeah, they're really good tips. Thanks, Sam. And Amanda, can I just ask you, what would be some of the commonest misunderstandings that you're having to correct with patients and maybe even your colleagues around same-day surgery?
Gosh, I don't know. We've been doing this for a while now in Grafton.
That feels normal. I'm sure it wasn't normal at the start.
Normal.
Like, cast your mind back to when it started. Yeah.
I suppose I would just emphasize that, while some of those patients looked really, really good in our videos and things, we do still have a variable response in that first month. There are a number of patients that still struggle, and going home earlier, having that ability to have a communication strategy, as Sam said, is really, really important. They need to know that we don't want you to suffer at home and feel like we need to know that if your pain is not well controlled, if you're not sure about something, you should pick up the phone. And so for us, that's managed largely, through our clinic, through the orthopedic centre, and through the administrative support and the specialist and myself. So patients do have a lot of open channels, and through some other messaging services that they receive. So they feel really confident that they can contact us. And I do actually field a fair amount of those calls and questions early on in the piece that may well come into primary care. And a lot of it is just them asking in those first 2 weeks, because they haven't done this before. Is this normal? My knee feels tight. Is this normal? My leg's bruised. Is this normal? There's a bruise on my foot or up my thigh. That's not my knee. Is this normal? So it's a lot of questions like that. And then obviously your usual stuff around pain management, wound review, looking at signs, if things are leaking beyond a week with their wounds, if you're the person looking after that, if there's indications of a clot, but a lot of times it's just people wanting to just be reassured, is this kind of normal? And we really push the point that, look, there's, you don't have to flog your new joint. Yes, you've got to get it moving and you've got to get up and move a bit, but there is also this kind of healing process taking place that we need to respect a little. And so we don't really encourage people in that first month to do hundreds and thousands of repetitions, from a physio perspective. So, doing enough to get the leg moving and get it going is enough. Yeah.
And in terms of communication down in Grafton, if someone has a question 2 days after operation, are they contacting you or are they contacting Sam? How does it work?
Both. I mean, I get emails. I guess they're sometimes calling up Amanda. I suppose the main thing is they feel comfortable contacting someone. I think if the area health really wanted to take this on, and so this is something that we've essentially done, offer, it's It's largely the resources that have been required have largely been paid for out of our clinic, privately. If the area health really wanted to take this on, having some sort of care coordinator that patients knew was the go-to person for questions would be very useful. But in the absence of that, we've been doing it ourselves.
Yeah, wow. So I guess for me, the take-home message is one, that making sure the patient feels supported so they know who to call and when to call when they got a question, which is standard general practice, saying that every day to patients. And then the other one is, I think I'm going to be stressing, will be that this isn't same-day surgery is not about trying to save money and kick you out because we've got a big backlog. It's actually about making your replacement journey a better experience.
Yeah, right. And if it's not that, we're doing it wrong.
Yeah.
Okay, so if it's not that, it's not going to work, and we're doing it wrong.
Yeah.
And which is sort of where that idea of first better and then faster, comes from.
Yeah.
Better care is the aim here, not cheaper. Cheaper and quicker are side effects of
fantastic side effects, but that's not the primary aim. Yeah.
Right. Yeah.
So, and then. So again, to everyone here, this all feels new. I know for you guys, it feels like you've been doing it for a while. So just a few questions around that. So just how novel is this in Australia and perhaps overseas at the moment, Sam? Is it just in pockets or is it widespread now?
It's reasonably novel in Australia. I mean, there's a couple of private hospitals in Sydney and Melbourne that have got contracts that sort of facilitate this. There's a unit in Ballarat that's been doing short stay arthroplasty. David Mitchell's been doing that. Often it comes up in regional areas, in fact, in small centres, which can be a little bit more quicker moving. So I think Ballarat and who was the other one that Alan Malloy was talking to? Wodonga or anyway, a couple of small regional areas, a bit similar to Grafton, where things like this are happening. The
regional centres, Australia, yeah,
right. The tertiary centres are really moving much more slowly. In Australia, this is quite novel. Overseas, I think New Zealand is quite similar to Australia in its practice, but if you head to Europe or America, this is quite normal. I visited a doctor in France, Dr Villemino, who does 90% of his knee replacements as day surgery. So, and obviously there's a bit of selection bias in terms of who comes to see him, but he was doing day surgery safely in very obese patients and older people and really all, almost all comers.
Yeah.
So,
well, it's just
in some places.
Yeah. So there's just another comment from another person who's a general surgeon saying that there's been enhanced recovery for bowel surgery for some time now, a few decades, and that GP education has been a major influence in making that improved, and that's evidence-based. So there's another thing. Good reason why we're doing this webinar tonight. So we've only got a few minutes left, but there is another question around public versus private. So I know that's maybe opening a can of worms, Sam, but just briefly, what are you seeing personally as the particular barriers to this becoming more normal in private hospital surgery?
So in the private system, I suppose there are some practitioners who think patients want to spend 5 days in hospital or 2 weeks in hospital because they paid for it. So there's that sort of expectation of the patients and the doctors. And then the other thing is the contracts often don't facilitate it. So the commercial in confidence contracts between the health provider and the health fund often really strongly disincentivize day surgery, in that the facility might get heavily penalised for sending a patient home too quickly. But that's something that that's gradually changing, but that's not changing very quickly.
No. And you work privately in Grafton too. Is that right? Coffs Harbour, I think you told me.
Coughs, yeah.
Coffs. Are you able to do same day surgery in your private practice yet?
So self-funded patients are obviously perfect. The patient, it depends who's paying, right? If the patient's paying for it, they think it's a great idea. In fact, if the health funds are paying for it, the patients would still think it's a good idea, but the hospital doesn't think it's a good idea because the hospital doesn't get paid properly. So it's this bizarre sort of triangle. So in some health funds are on board with it. So I think NIB and Medibank are sort of getting on board with it, and other health funds are slower to move. So it's quite an interesting
process.
Area.
Cultural shift, yeah.
And all those details are actually commercial in confidence contracts that I don't really have the details of.
Yeah.
But I've just noticed that the hospital is happier for NIB patients to go home quicker than the other ones.
I bet, yeah, that's interesting too about being self-funded, because I know some patients I have who want to have self-funded surgery. The hospitalisation is some of the major cost.
Right.
So obviously there's the joint itself and the your time, the anaesthetic time, but I hadn't thought about that before. So that's an interesting point.
No, for self-funded patients, this is obviously ideal. It's better, right? So they're paying less for a better experience.
Yeah. Look, unfortunately that's all we've got time for tonight. That's been a fascinating talk, Sam and Amanda. Thanks so much. I just want to congratulate you both personally again about being at the forefront of this change in surgery, and that it's only just down the road from where we live, which is great. I think I made a joke to Sam that I'm probably technically within an hour from Grafton now, so although I'd probably have to go private, so Coffs is 2.5 hours, so I might miss out. But there's the hurry up for the local surgeons when I'll eventually, maybe, who knows, one day need one of these operations. So yeah, that's great. Thank you so much again for coming along. Just a quick mention to EBM Analytics, which is a research an analytical organisation that Sam uses to do the research for his patients. So thank you to them. Without our sponsors, it's difficult for us to run these events. And thanks for coming along to another Nordocs webinar. Please remember that you can look at our previous webinars through our website and leave us some feedback from today. So thank you all for attending, and we'll see you next time.